So this panel is titled Healthcare in the Gulf, an Investment Opportunity. So allow me to introduce our esteemed panelists. Dr. Sami Alom, he's the Director of Casamar Holdings. Welcome, Dr. Sami. Prior to joining Casamar Holdings, Dr. Sami was the Chief Strategy Officer and Director of Investor Relations of Noor Hospitals Group. Dr. Nadeem Al-Duaij is the co-founder and CEO of Sahati. Dr. Nadeem has 20 years of experience spanning from entrepreneurship, academia, and clinical medicine. Prior to co-founding Sahati, Dr. Nadeem was the Chief of Emergency Medicine at Dar Al-Shifa Hospital, Senior Consultant Emergency Physician at Geneva Hospital, and an attending physician at Harvard Medical. Thank you for being here, Dr. Nadeem.
Pleasure.
And last but not least, we have Mr. Mash'al Hamid Kanu. He's the chairman of Kanu Group. Kanu Group is the largest independent family-owned business and it's established in 1890. The Kanu Group activities span multiple sectors like shipping, travel, logistics, oil and gas. Mr. Mash'al has 2 MBAs, one of which are from the University of St. Thomas, Texas, and one is from right here in the UAE from the AOS. Thank you for being here, Mr. Mash'al. Let's get started with this panel. So, healthcare in the Gulf, an investment opportunity. Dr. Nadeem, I want to get started with you. In the past couple of years, we've been seeing this trend in the Middle East when it comes to healthcare, that it's more Botox treatment, it's more the glorified spa that we just call a hospital. Is this an accurate view or is it just me?
Well, it's the visible. It's what's visible to a lot of people, right? I mean, I think healthcare has been growing in terms of its not only quantity but also in its quality, right? And the different services that are provided. There's more and more capacity that's being built into these systems. But of course, there are a lot of challenges, right? And I think, you know, we're all about the glitz. We're all about the short-term gains, right? That's kind of our culture. You know, the quick fix. And so when we talk about quick fix, we talk about, yes, traditionally, you know, the plastic surgeries, the gastric bypass surgeries, you know, all those very rewarding monetarily interventions, but not necessarily rewarding in the long term for population health. I think in my perspective as a public health person, I would argue that we've built our systems on the wrong foundations, or actually very frail foundations, which should be primary and preventive healthcare, right? That's how you build a proper system. The base of the pyramid has to be primary and preventive care. And we've neglected that. We've kind of focused on building nice and big, beautiful hospitals. And we're doing more of that. So doing more of the same is not necessarily a good thing. I think it's necessary, right? Because there's a balance between curative and preventive care, but we've neglected for far too long. And that explains also why you're now seeing this massive burden of disease in the region, right? We have the fastest growing chronic disease mortality rate in the world. Despite pouring billions into healthcare every year, it's because we're doing it in the wrong way. We're focusing on the wrong priorities. That's my view on that. But I'll let my co-panelists also.
Dr. Sami, you've been in the investor relations space, certainly directing the money towards one type or the other of medical investment. What's your view on that?
I can give you 2. Let me start with what I might have given you 5 to 10 years ago. So a lot of what Dr. Nadeem is absolutely right and continues to be correct. There is underinvestment in primary care and preventive care. On the investing side, so on the private side, if you like, so not from the government side, yes, a lot of shiny hospitals. You have a lot of investors that come from backgrounds in construction and hospitality, that approach it in that manner, right? So we have hospitals with wonderful lobbies. I know of one here in Abu Dhabi where I'm sitting that has a piano in the lobby.
Yes, I know which one you're talking about.
So there's a lot of that, and you have to wonder, remove yourself from being a healthcare professional. You have to wonder, is that a cover, right? In the absence of substance, is that a cover? Fast forward to today, I like the intersection of healthcare and IT. I think there's a tremendous amount to be done there, particularly in regards to non-communicable diseases, addressing a lot of the things that Nadeem mentioned, and hopefully we can get into that further in the talk.
Okay, Mr. Mash'al, we're going to head over to you. Your thoughts on the topic?
There are 2 aspects to consider. First, I will speak as an investor.
Exactly.
The other one, I'll speak in as a user of these, as I'm not a doctor. I'm pretty much a layman in this aspect. As an investor, sad to say that this is actually something that is financially very viable and very lucrative to be in. If you look at the profit margins that hospitals make, and investors in hospitals make of these things, it becomes a thing that feeds itself, because when you have so much, you can make easy money, you start thinking it's easier and easier to go. Look at how hospitals treat the insurance companies, look how insurance companies treat the patients, and so on and so forth. And all of them are making fat margins off the patients, and at one point making fat margins off the government because they have to pay for these things. And you can see this is a spiraling structure where it becomes harder and harder to remove people from the cash cow. It just produces a lot. That's from an investment perspective. And to be honest, I'd agree with Dr. Sami in terms of where things are going to go. It's technology. It is really, really reaching the point where technology is going to supersede hospitals over time. It won't happen tomorrow, but it's happening faster than people perceive. For example, there are several companies that just through just taking a picture of your face will give you to a certain amount of accuracy what type of diseases you either have or potentially could have by the look of your eye, the look of your face, the draw of falling of your cheeks, etc. Because again, falling back on big data and AI in terms of how they utilize this thing. Once this starts to happen, really, why would you need to go to a hospital? Because the chances of you going to hospital not being sick and leaving there not being sick becomes smaller and smaller, because as we go into a hospital, the chances of you catching something from someone becomes harder and harder. But I'd like to pick up on Dr. Nadim's point, which is very important. And this is sadly something that we don't even think about. It's preventative before it is curative. I don't know if that's the right word.
Yep.
I want to prevent these issues. First and foremost, what are we doing regarding food? And food doesn't happen by taxing things. You know, soda drinks were 100% taxed. It doesn't really matter because I'm rich enough, I will pay for it, I will still get it. What needs to change should be from a nutritional point of view in terms of educating our kids from the beginning what to eat. Get off, pardon me, forgive me, but get off your proverbial ass and exercise. Do something. You know, yes, I'm playing football. No, you're not. You're playing FIFA on TV. Exercising. Get off your ass and exercise. Get off your ass and do something. Eat less fatty food. But the problem is fatty foods are available in abundance. It's cheap. We don't have so many pavements. We don't have so many parks. We don't have people encouraging us to do this. It's like, we suggest you do that, but it's not pushing people towards that. Then obviously, and we have a tendency, sad to tell you, as genetics, I was actually told this by a professor in genetics, that we, within the Arabian Peninsula, are perfect subjects for testing genetics on diabetes because of the family tree not really branching out so much. So we have a tendency to become fatter and sicker. The same doctor said something which actually made me sad. For once, I was proud to be an Arab and sad at the same time. And I'll tell you why. He said the genetic body structure of a Chinese is they don't become fat per se because they've been trained, the cells have been trained that the food will come in and they dispose of it because they know other food is still going to come in. That again, by the way, if it's true or not true, I don't know. That's what he told me about 20 years ago. He said the Arab body, the Bedouin, is so disposed to storing, and we are so efficient. For the one time we as Arabs are efficient, I really don't want it to be the case. Our cells are so efficient that any food that comes in gets stored. Now, if you think about the type of foods that we eat, majbouz, harissa, bariya, pick any of these foods that we eat, it's full fat. I mean, full fat. We have this lovely dahl khaldi, which we have to have this. No. And halawa, the sweets, I won't begin describing how much fat and sugar is in this. But that works fantastic if you are a Bedouin moving from place to place and your body is constantly needing energy to be burned. but we have a sedentary life. We're sitting doing nothing most of the time, and we're eating. So yeah, as far as an investment is concerned in hospitals right now, we have a beautiful chain of people coming through who are going to make you a lot of money. However, again, if we're looking at it from a health perspective, I would rather focus on trying to prevent these things and save the government. Hopefully the government will try to save itself. And we as investors will be able to focus on the more important things, such as technology in healthcare, in terms of how to make life better and give us a better, what you call it, a return on our investment, rather than building, sadly, glorified, huge buildings that are wonderful from the outside, but it's like having a great hardware, but mediocre software. I'd rather have fantastic software, even if the hardware looks horrible.
Dr. Nadeem, I'm going to move on to you with my next question. So right now you moved on to the more entrepreneurial side of things with Sahati. Can you explain to us more what Sahati is all about?
Yeah, so really, I mean, taking kind of all these years of experience in both, global health and in medicine to see how we can actually use technology to improve health and to focus on things like primary and preventive care, right? So today, I mean, as my co-panelists have said, we have the tools to really be able to reach out to the community, right, in a very efficient way, right? All you need is a smartphone and an internet connection, and you can do a whole lot with that, right? So Sahati seeks to build kind of this virtual health system where we put much more emphasis on primary care. So our idea is to really we focus on the paradigm of primary care for all. So we offer a telehealth service that then assigns each patient to a primary care doctor because we believe in the virtual first approach. I think we've now had like 30 plus years of experience with telehealth, and we know that depending on the studies that you look at, 50 to 70% of all of in-person healthcare can be done online. So that's a massive market. And we want to capture this market by offering services. And we know that مثلا in Saudiya, in Saudi, where there's a huge amount of healthcare deserts, where mortality rates are extremely variable, we can reach out to those communities, right, through their mobile phones. The idea here is really to be able to do as much as you can at home. Right, and so we've also integrated remote patient monitoring. Right, that's also the future of healthcare, is being able to monitor more and more things at home. Right, starting from the basic things, the vital signs, the steps, the sleep patterns, but going all the way to more advanced cardiopulmonary monitoring, pregnancy monitoring. There's a lot of devices that are coming out that are phenomenal and that integrate seamlessly into various telehealth platforms. So we're not interested in looking at verticals. I think we've looked at verticals too much in the region, right? Either building hospitals or focusing on one vertical. Health doesn't work that way. Health works in a horizontal manner. It has to be a horizontally integrated system, and where the hospital should be the last step, right? Because remember, if you look at the population curve, let's take the blood pressure curve, right? It's a bell curve. Mm-hmm. We have for decades we focused on the tail end of this curve, the sick patients, right? We've poured billions and billions into treating the sick, and we're ignoring that tsunami that's arriving, right? From the ones as you've all mentioned, the ones that are exposed to risk factors that we're not addressing at all, and they're exposed. They have no primary care provider to tell them, come for your annual cholesterol checks, come for your pap smears, and they get sick. So we're just, as you mentioned rightly, that there's this kind of steady stream of patients that will keep coming and in increasing numbers. That's not going to fix our health problems.
So, Dr. Sami, I wanted to ask you a question. Like Mr. Mashal said, the reason why the system works the way it is right now is because that's where the money is flowing. Insurance, this is where everybody makes their money. How can we go forward and align the industry in a way where the money is being made more on the preventive end than it is on the elective treatment end? Is there a way that we can get there?
There must be. You're right in that the incentives are not aligned correctly to achieve those outcomes, right? The incentives, for the most part, are there for treating people when they come to you with a problem. There has been quite a bit of experimentation on the pay for quality or pay for performance side. There are several ways to do this. I have been outside of this for about 5 years, so others may be better positioned to comment than I am. I don't know where that has arrived. I know here in Abu Dhabi, there is an attempt to implement it, and I get the feeling that it hasn't, right? It's tricky. It's really tricky. You have a lot of stakeholders, providers push back, right? Be it hospitals or healthcare professionals. There's always a lot of pushback. No one wants to do it. No one wants to adapt. But if we want to achieve the right outcomes for the population, it's something that we are going to have to do. If you don't mind, I want to go back to your previous question to Nadeem and his response, because I think that's worth exploring a bit more. And I want our listeners to know, viewers and listeners to know that this is achievable, right? There are companies out there that are doing this at the moment, and I'll provide one as an example, which I absolutely love. It was a listed company that was absorbed by another one, and it's called Livongo. And Livongo is phenomenal, right? And the way it works is it works through an employer. They started with diabetes, they moved on to hypertension and a couple of other things. And so the employer pays an amount per member per month for that member, that employee, to have access to the app. And if it's diabetes, they get sent the device that's connected to the phone and the strips and so on, so that the member doesn't have to do anything. And the app constantly is reminding you, you've just woken up, you need a reading, right? Have you done that? It even checks on your mood. It advises you to exercise. If you have a spike, right, it tells you have a couple of glasses of water and go for a 15-minute walk and then measure again, right? If you have a serious problem, you get a call. And what I find most remarkable about this company is the results, right? Within a year of being on the app, the average patient has brought down their HbA1c score, which is a score of long-term exposure to high glucose, if you like, by 0.8. So to give you an idea, healthy people tend to be in the 5s, maybe 6s. People who are very diabetic tend to be in the 8s, right? So it's a significant drop. Hypertension drops by 10 millimeters of mercury. Weight comes down by 7%. So these are real achievements, right, for people who've been on this for 1 year. This is what gets me excited about investing in health, much more so than buildings and beds and equipment.
That's great. Mr. Mashal, do you have anything to add to what they just said?
I just to follow up on what Dr. Sami said, while he was talking, the one thing that was coming in my mind is there is a very fine line, and it's nothing to do with anything he said per se, but it's the general idea. There is a very thin line, and it's starting to creep as to your health, your requirements, and somebody knowing personal information. In certain countries, you have a delineation that stops certain, theoretically, stops certain people understanding and knowing more about you than you want them to know. Because now, the moment you start doing everything, I mean, we get angry now with companies like, I don't know, like Google or Amazon, who track us in our shopping. Shopping is something secondary. It's annoying that people know what we're buying, what we're not buying. But when you start talking about my health, you know exactly what I'm doing, where I'm sitting, what I'm moving. This starts to become very intrusive. There will be some pushback. When it happens, I don't know. But this is just a general statement. In terms of investments, because I think this is the idea in terms of what we're trying to talk about, is technology going to become more and more fine-tuned? The answer is yes. And the more fine-tuned it becomes, the more you will be able to financially benefit out of it. I agree. You know what? There is always going to be pushback from people who have built a hospital. I mean, a hospital, you're going to need 20 years or 25 years to recover your money. If you've been a small clinic, you might need 5 years or so. But if you roll out a new technology that can erase all of that, then I don't need to go to a hospital. I don't need to have, and you start seeing that the person who's invested millions, in some cases, organizations have spent billions on these things are going to say, no. I need to recover my money. So of course, no one is ever going to come in your face and say, you know what? No, we don't like this. They'll never do that, because at the end of the day, no one wants to look like the Neanderthal in that industry. But you will have that. It's these passive aggressive people who will go out of their way to try to find ways to block you. Technology is important. The key for us is to understand in investing is whether we're investing in a technology that has an end use, or we're investing in technology for the sake of technology. Just because I can add a few more things in terms of technology in healthcare doesn't necessarily mean that it's something I really want or I can actually utilize. Everything needs time to be acclimatized. We are not ready for shocks to the system, usually don't survive, even if they're good, but the shocks to the system usually don't survive. But things that are gradually, over time, allowed to evolve in people's mind, in the people's psyche, to allow them to absorb these new thoughts and ideas, these are the ones that pick up. So in some cases, the first mover advantage that people think is actually good in investment might actually be negative because it's the shock and people are not ready for it. It's the second one who comes in after and says, okay, now I learned this method doesn't work. It's the technology that works, but this method doesn't work in the society. So let's find another way to get this idea or this technology into society. That one might actually be the winning horse, if you want, in terms of investment. It's not necessarily that I want to be in the main driver of any technology. It's the one that I see having traction. This is key from an investment perspective. And I'm trying to focus, honestly, I'm trying to focus on the investment side because I'm not a doctor. I'm not in the healthcare industry per se, but I do invest in companies that do healthcare and new technologies within healthcare.
Dr. Nadeem, yeah, go ahead.
Yeah, I just wanted to add, I totally agree. And I think that's a key point to make is that, technology is not an endpoint, right? Technology is a support system, right? It enhances whatever you have. And I think, one critical, a couple of critical points to keep in mind is that before getting into any disruptive technologies or disruptive initiatives, I think you really need to understand the local culture and sensitivities and needs, right? Consistently, it's not about providing a communication platform like the one we're on now, right? That doesn't really help, or even providing, the user with 10,000 doctors on a list, right? That doesn't help me as a patient. I want to know that I go into a system that is of high quality. One, we have a big challenge, which is very specific to our region, is the variability of quality of healthcare professionals, right? They come from all over the world, very little standardization, not great regulation, and patients suffer from that, right? And the lack of guidance to the right services, right? People consistently, you ask everyone around you, where do you go for this? Where do you go for that? Do I go see a neurologist for my headache? Do I go see a cardiologist for my palpitations? No, you don't. And 99.999% of people, I am sure in your experience as well, do not have a primary care doctor, right? That's the major gap in the system that needs to be addressed. And to look at a parallel, which is not that dissimilar to our region, but looking at the US, which is also a highly fragmented health system, extremely expensive, focused almost purely on curative care. Their primary care market is upwards of $240 billion. It's a massive market. We believe that the market is there here as well, because there's clearly a need. The government's not doing what it's meant to do in countries where that's kind of the majority stakeholder. But so there is an opportunity. It's just about how you get to that, right? And it's really understanding, again, the local norms and cultures and needs.
Dr. Nadeem, I'm glad you brought up the fact that the variable healthcare provided by doctors and how fragmented and how that there's no standardization. What's the difference in doctor quality between, and you've seen that, you've touched it yourself. What's the difference between the doctors, the ones that graduated from the US and the ones that graduated from the Arab world? Is there any difference?
So no, I don't want to compare it in that way. I think there are excellent doctors in all systems of care, and with all training backgrounds. But it's really more about how we select them, how we kind of where we place them, and what kind of jobs they do. I think that's really the thing, that the variability, and it's also remembering the incentives. And I think one thing, everything comes back to incentive, right? I mean, one of the reasons Sami and I were teaching at UAE University back in the day is to tell people that it's not about, you know, the individual, right? It's about the system, right? For the moment, at least in Kuwait, and I know it's fairly similar in other countries, the financial incentives are not there, right? Private sector remains focused purely on concierge services because they only cater to out of pocket or to a handful of insured people, and so you're going to cater to that. You're not going to be able to bring in primary care or do all that kind of, you know, health system approach thing. So and of course the regulation, right? So how do you verify credentials? How do you verify the quality of the care? How do you enforce you know, continuous professional education and development? Those are things that we're not able to do quite yet. So it's not so much a question of where they trained, but more kind of the environment they're in and how they can be incentivized to do the right things. And right now there's a lot of negative incentives, unfortunately, at least in our health system, where, you know, big example is the commissions, right? Like, you know, in private sector, doctors take commissions for labs and pharmaceuticals, which is like the worst thing you could ever think of doing in healthcare, and yet it happens, you know, profusely within the system. So those are examples of how you can provide bad care and very dangerous care, right, to many patients, and they get lost. And of course, when they don't have a care coordinator, they become their own care coordinator. And of course, the information asymmetry is so grand in health that they obviously the patient will not know what to do or where to go.
Dr. Sami, I'm going to ask you a question, the same question I asked Dr. Nadeem, but in a different way. You have been working in investor relations with Noor Hospital, and you must have noticed that Western trained doctors tend to get paid exponentially more than Arab trained doctors. Is that an accurate observation?
It wouldn't be for Al Noor, so I can speak for Al
not
Noor.
Al Noor. In general, let's talk in general. Is that an accurate observation?
I don't know. I don't know what it was for other hospitals. The observation I can tell you is that we paid people for the skills that they brought in, right? So people got paid in accordance to the skills and the experience that they had. It may be that some Western doctors can, or Western trained, I should say, doctors might be able to do procedures that those trained elsewhere cannot do, right? In which case they would be able to command higher compensation. But I don't agree with the first statement that you made. I certainly haven't seen that.
It's not accurate. Dr. Nadeem, is that not accurate on my part? The fact that some Western trained doctors, given the same qualifications as an Arab trained doctor, they get paid more.
Well, I think, like Sami said, I think it really depends on the system that you're working at. I think it's per health system or per hospital system, and yes, I've seen it in Kuwait in certain locations, but I don't know if it's generalizable. I mean, I don't know if we can generalize that across the board. I think that yes, I mean, it's a brand for the hospital, right, of having a Western trained physician. But yeah, I mean, I don't have the evidence to tell you that, you know, this is yes across the board the case.
Do we have a reason of why that, if it is happening again, do we have a reason of why that's happening? Why is it a marketing point for hospitals to boast it right in front of their marketing material? Mr. Mashali, you feel free to jump in at any moment.
If you don't mind, I'd like to take that one. It's not just medical. It's a perception. There is a perception. Anything coming from the West, sadly to say, anything coming from the West is perceived to be superior. We have been indoctrinated for the last just to make you understand this a bit in terms of why we think along those lines. If you took history in any Arab country, you would have seen, they would have taught us as students about the Islamic period. It stops about 1200, 1300, and then there's a skip, and we start talking about the European inventions, etc., how wonderful they are from the 1600 onward. And so now, even I'm sadly to tell you, if you've talked to most of our people, most of Arab students, who's the first person to ever fly? Oh, the Wilbur brothers. No, they aren't. It was Abbas bin Farnas. But you know what? and they have a strange way of looking at him. And the reason is because there has been indoctrination that we reach a point that we start thinking just because it comes from the West, it has to be better than anyone else. Technologically speaking, I'm pretty sure other countries, whether it's, again, I'm not a doctor, I can't specifically say this with 100% knowledge, but I'm sure that there are doctors and technology that's coming out from China, from India, from Russia, etc. That would be on par, if not better. I can't tell you exactly if that's the case or not. Looking forward, I think it will be the case. But right now, it's a perception. If you ask me personally, which doctor would I choose? A doctor from India or a doctor from the West? I will tell you, a doctor from India would be much more closer to my heart for a couple of reasons. One, if he's trained in India, he's seen diseases like nobody else has seen. That's the first one. The second part is, because he has nearly crappy resources compared to the one in the West, he will find a way to resolve the problem that others cannot find. So that's why I want that methodical and analytic mind to think more than the one who already has, because I have fallbacks. If I'm coming from the West, I have fallbacks. I can fall back on technology, I can fall back on pharmaceutical, I can fall back on because money is available. Someone coming in from India, money is not so much available, well, so at least until recently. They are seeing diseases nobody else has seen. They find ways to treat these diseases, or at least hopefully attempt to treat these diseases, because with limited resources. And it comes back to a very stupid example, but forgive me, because this is just to give you, it's a mindset. When India landed a rocket, I think, on the moon, and I think it cost some $50 million or something along those lines, and compared to how many billions were spent by NASA. And when the chief scientist was asked the question, the one who was running the show, I can't remember her name off the top of my head, but she said, because that was my budget. It wasn't because we could, that's my budget. I was given a budget. This is what I'm going to do. I'm going to fulfill it. I'm going to land a spaceship onto the moon because this is my budget. End of subject. So for her, it's, I have very limited resources. I have to fix something. I will try to approach it. It's a mindset. We unfortunately have a mindset, at least in the Gulf. I can't speak for the rest of the Arab world, but at least in the Gulf. We have a mindset that thinks if it comes from the West, if it's British, if it's French, if it's German, if it's American, or Canadian, it has to be good. Like in any system, there are good things, there are bad things. But I need to assess for myself what is good and what is bad. I need to also assess the thing, what you call, from an investment perspective, in a way, if I would be taking this one forward, is to do a trip advisor for doctors. When you like something, you put a comment, you rate people. At least then to a certain degree, because let's face it, one of the issues you can have with doctors, interacting with doctors, is they might be perfect in what they, their knowledge, but their, what do you call this, bedside manner.
Bedside manner, yeah.
It's horrible. And I would rather have somebody, talk to me in a nice way, make me feel more comfortable, even if he or she cannot necessarily fix my problem, giving me enough time, because, let's face it, psychologically too, the body can help itself. But if you hit it with something that's hard, the body is going to automatically, no matter how much medicine you put towards it, the body is already fighting it. But if you give it a bit of confidence, then the body starts to at least build some sort of defense, if you want. It's not just medicine; it's also psychology. That's what the placebo effect actually does show sometimes, that even without medicine, the body can react because the mind is able to help. There's an old saying, "Body heal thyself." I'm not a doctor. I don't know to what degree this is correct. I can't say everything can be healed by that, but to a certain degree, I'm pretty sure psychologically, we as humans can help ourselves. But having the person who holds our hands to make us feel comfortable enough to do that, this, I think, is much more important than whether he is trained in this place or that place. But again, this is just my personal opinion.
That's great. Dr. Nadeem, I wanted to ask you a question now pertaining to the education of doctors. What are we missing?
We're missing a lot, and not just here in the region. I mean, across the board, I can tell you, even in the most developed health systems, we're missing. I think and things are gradually changing, but I think we're still a very traditional, educational system, right? Where we're taught by subjects, we're taught by, um, and to heal or to take care of a patient, right? To manage a patient. But we don't necessarily understand how health systems work, right? We don't have that input of what are the incentives in the system, what makes for a proper health system. We don't, of course, technology is a huge part that's gradually creeping into the use of healthcare providers, but still not in terms of education, right? Of how can you use technology to empower providers, right? And I think the reasons for that are as you see in the practice of medicine, we're still too many doctors in those very traditional systems. And here's one of them, but I spent most of my life in Switzerland, and it's also a very, very traditional system. It's focused on based on hierarchy, right? So the intern says, "Oh no, I'm following what my chief resident is telling me to do." I'm like, no, this is 2020, things have changed. These processes have changed. Read the literature. So there's a reluctance to critiquing ourselves, to write. The self-criticism doesn't really exist in healthcare, and that's one of the major problems of both the education of healthcare, but also the practice of medicine. And I think that's that. It's kind of the understanding that health is not just a collection of organs that you're trying to stabilize or make work. It's the social environment, right? It's your socioeconomic status. It's the social network that you have. It's the air in the quality of the air that you're breathing. As Mishra said, the food that you're eating, right? And that is not yet completely immersed in our educational experience. And so we continue to produce very kind of narrow-minded professionals that then takes a while to get them to understand the rest of the puzzle. Yeah.
Dr. Sami.
I don't know what else I can add. Well, the systems thinking, right, which is what Nadeem just said, that applies to all professions, right? People in general are not great at thinking up here, and everyone gets down in the detail. And healthcare professionals in general, doctors maybe are notorious for that, again, because of our training systems. More specifically, again, echoing what Nadeem said, financing and technology, right? Technology is self-explanatory. By financing, I mean, if everyone who worked in the healthcare system understood how the dollars, dirhams, rials, whatever it is, move about the system, I think you'd have a much more cost-conscious segment.
That's great. Mr. Mashal?
Again,
you don't need to preface. We understand.
In this field, it's kind of hard for people to say anything. Other than, I just want to add one thing, and it's just an observation. There is a very strong, actually, and I understand that from in surgery, where you need to have a very strong hierarchy where the person who's the doctor in charge, everyone has to listen to him or her, because it's critical. The person will die. But you have something similar in the airline industry, where the pilot is the boss, the head honcho, and everything had to go through. And it took an air crash like the one of Air Korea a few decades ago to change the mindset, because what the fear was by the co-pilot and everyone under is, how can I challenge my boss? He knows better than I do. And he's the pilot who's been the pilot for the last 30 years or whatever the case is. He's been on this many flights. He knows exactly what to do. Our hierarchy says, I can nudge him by giving him more information, but I cannot counter his position, because if I do that, then there's chaos and everything will go wrong. But it took a crash like this for the whole system in the airline industry to say, you know what? No. You actually have, if you have critical information, you need to talk to the pilot, and in some cases, if need be, override him or her. The fear why, when you have a person in low ranking going up to the one on top and going to the one on top, is there's a constant fear. If I challenge, even if I'm right, if I challenge my superior, I might win this battle, but I'm going to lose the war. They'll find me on the way out. And I don't want that. You know what? It's okay. I don't mind. I'm going to, what you call, I won't say anything because let somebody else, what you call, take the blame if something goes wrong. It's not my fault. It's a mentality. How do we overcome this? Well, the sad thing is in the case of whether it's, forgive me, Dr. Nadim and Dr. Sami, this is your field more than mine, but whether how to overcome it in the as a doctor, how to overcome it as even in a pilot, both of them are critical. Meaning you make a mistake and somebody dies. This is not a, oops, I made a mistake and let me fix it later. No, no, no. This is, oops, I made a mistake and somebody dies. How do we fix this so that I still need to be in control, but I still need to bring in my juniors to tell me if I've made a mistake, if I've done something wrong, how to help correct it. Because the key is not me as the head doctor or head, whatever the position is. The key is making sure that the patient is safe and getting that done right. This part, it's a again, it's an education. How do we get people to get educated in these things? I don't know. Honestly, I can see the issue, but I'm not the person who's able to fix it.
Dr. Nadim, my question to you is, right now with the Sahati, how are you planning on driving patient adoption? We see majority of patients in the Arab world are used to going to the doctor themselves. They're used to doing everything in person. How are you planning on turning that switch around?
It's a great question, and I'm going to speak generally speaking, not just about what we're doing, but in general, kind of what technology companies are doing. I mean, we look at other sectors, right? Look at the food industry, look at what Talabat has achieved over the years, right? Of converting these people to, because at the beginning it was tough, right? It's at the beginning, like every beginning, it's difficult to change your habits, right?
Mm-hmm.
And so I think it's, again, there's knowing that maybe not all will adopt this right from the get-go, but it's about providing a very simple and user-friendly user experience, right? It's about addressing the needs, really the needs, and that's because people will try things, right? They'll try things fairly easily. It's not difficult to download an app or go onto a website, but it's about the output and what you get out of it, right? If you I've practiced for all those years in medicine, and despite being an ER doctor where you don't really have the time, you kind of run around a lot, I always made sure that I took the extra minute or two to explain things, right? So why, for example, don't you need antibiotics for your sore throat, right? Why do 9 out of 10 sore throats are viral? Don't need antibiotics. Same thing here. It's about listening to the patient and addressing that concern, right? So being able to listen, address their issues, that's the key. It's not about replicating the physical world on the digital space, right? It's about providing a different experience. So one is definitely the technology has to be very simple to use, right? You have to understand it and you have to know what you're getting out of it. But the actual experience of interacting with a provider in general, because it's not just doctors, right? It's nutritionists, it's physical therapists, it's all sorts of different. Wellness is a big part of addressing the chronic disease burden that we have. So making sure that we have an end-to-end solution, right? Because people, what are people looking for? They're looking for convenience when they're like, I don't want to wait in traffic. I don't want to wait in a busy waiting room. When I'm going to spend, it takes weeks to get an appointment, and then you end up spending, 10, 15 minutes with a doctor. That's not really, cost effective, right? So you can now have access to a doctor much quicker. But the is that you want to make sure that you're giving them everything they need, and that they don't have to call some other place to get their medications and all that. That you offer them an end-to-end solution. I think that's the key to the future of digital health, is making sure that when patients come in, to be able to acquire them and retain them, you want to make sure that you're offering you're addressing all their needs, right? So home delivery of medications, home visits for blood tests, because most of that will address the needs, and then only a few of those will have to go in to be seen physically, and then you're sending them to the right place, and that's the key. And I think to complete the circle, I mean, to add to the Livongo model, I think there some really interesting primary care or hybrid primary care models like One Medical, which is just IPOing, which IPO'd and like IPO last year actually, where you have a system that is addressing that gap in the market, but it's offering also a virtual first approach wherever you can see your doctor online, and then they have these physical spaces, these clinics that are super friendly, welcoming, modern, where the doctor is at the same level as the patient, and that's one of the challenges we have, right? Almost 20 years I have not worn a lab coat, except when I worked in Switzerland and here in Kuwait. So it's because you have to be at that level, right? I don't like to be called doctor, for example, right? My patients call me Nadim, as everyone else does. That brings you back to a level where you can interact with everyone, where there isn't those barriers that you're setting. We're very good at putting barriers here, and that's really not good.
Exactly.
Yeah.
Dr. Sami.
Question?
The same question. Patient adoption of new technologies. How can we better affect patient education?
I don't know where to go with that. I mean, your question was posed to Nadim in terms of getting people onto Sahati. So in terms of again, going back to Livongo, which is an example that I know, it's employer driven. That's not to say that's the only way to do it. I think Nadim's example of the food apps getting people on is great, right? And Kuwait in particular, in terms of per capita usage of food apps, I think is perhaps the highest in the world. And it's become the norm to do this. So I would think inevitably it's going to be the same for healthcare, right? Accessing apps. We did see during the pandemic, obviously has accelerated that, right? Teladoc has had a tremendous growth in the number of people accessing their platform throughout the last 12 months. So hopefully that helps. I think people under 40 are probably more amenable to using this than people over 40. So as time goes, more of us will feel comfortable using these technologies. And hopefully people will see the benefits, right? Time, cost, maybe even experience.
Mr. Rashad.
I don't know how I can add to that, but
you can answer it from leaning on your experiences in other fields. It doesn't have to be the same field.
By the way, there's just one comment I'd like to bring up following what yes, Dr. Nadim said. There is an issue in our psyche as well in this region. We like authority. And the moment you lower that, for some people, it works beautifully because now I can feel comfortable and start opening up. In some cases, if you're not the authority, then whatever you tell me, I will put it aside and go and find someone who is an authority. In my head, I have had people who tell me, call me, I'm not, but they call me doctor. And I keep on telling them, I'm not. I don't have a doctorate degree. I'm not a doctor. But in their head, if I'm not, then why am I listening to you? All right. So you need to, there are some patients who need to hear that. Fine. The other issue which I'd be worried about also is a question of communication. Because what words I use, meaning something that's very simple and easy, some other person will take it as something drastic and dramatic. And I might not understand that he or she is receiving what I said in a different method than what I'm saying. Then you have the issue of languages. Forget that was just tonation and a definition of words. Then you have the issue of language. Sadly to say, when people think, what you call it, patients from India, they think, well, they speak Hindi. No, they don't. There are over 200 languages, and some people don't even speak. The reason why English is the unifying language of India is because they don't speak Hindi, but we think they do. And Punjabi is different than Malayalam is different than Tagalog. You have the different languages, but what words are used in this language might be completely different than used in a second language. But because we think of them as one way of communicating with them. There's a lot of, we are humans, and because we are humans, we have a lot of complexities that come with us. how do we address them? Because in some cases, me personally, I actually follow Nadim's formula. I like being informal. It makes life easier and you can get things done because people are less, what you call it, guarded when there's more informality. But if you want to get something done immediately, formality actually works because you're saying, as an authoritative figure, do it. It's not a suggestion. It's not an idea. Do it. And so you need to get this done. How do you balance between the relaxed view where I allow people to give me back input so that I can actually utilize this input that they give me in what I'm doing, in the case of a doctor, maybe in terms of diagnostics, because the person is less afraid, so he starts telling me more about what he or she ate or he or she did or he or she's doing, which I can actually utilize in my formula in terms of how to address the issue they have. But after they've done that, and I tell them what they should be doing to fix or address the issue, they look and say, because it's an informal way of interacting with one another, it's okay. I don't have to listen to them. You end up look at the issue we have with the issue of antibiotic. The reason we are theoretically the antibiotics is becoming more and more. The bacteria is becoming bacteria. Is that correct? Is becoming more and more resistant to the antibiotics. Is because we take half the dose, we feel better, and throw the rest, and therefore we're not actually doing what we're supposed to do as per the doctor. Why do we do this? Is because we feel that the doctor has just told us, you need to do this for a while. Why? There is no feeling that I have to continue the full dose because I feel better. If I felt my doctor was very authoritative and I had to fulfill what he said or she said, I would fulfill the whole regimen. But if I feel that, it's okay, I do it, I feel better, toss it away, and we start again. This is a perception I have. As I said, I'm not a doctor, I'm not in the medical field. This is what I keep on reading about and hearing of. If I'm wrong, we have two fantastic doctors when you come on the panel. Please correct me.
Okay, we're gonna go ahead with closing remarks. Does anybody, one final remark, one final comment to sum everything up? Dr. Sami.
Well, I think it's a pity we didn't get time to explore a lot of interesting areas of investment in healthcare, like gene sequencing, gene editing.
Okay.
There's a lot being done in that field. Digital health, I think, is something fun to explore. And there's just a ton being done there that's more interesting than traditional healthcare.
So in terms of gene sequencing, what are the upcoming trends? Well, what's happening right now?
Well, the cost of sequencing someone's genome is dropping faster than Moore's law would predict. And that is an absolute game changer. At the beginning of the century, it used to cost about $1 million to do that. Now it's under 1,000. It's about 800. I wouldn't be surprised if we got it down to 100, certainly in our lifetimes. And could it be as routine as getting your blood sugar measured, CBC? I think so. I think it'll be very much incorporated into very standard healthcare.
For the non-healthcare professionals like myself and Mr. Mashal, what does gene sequencing do? How can it be a game changer?
So we all have unique genomes unless we are identical twins, and that can inform your susceptibility to particular diseases, how you may respond to particular treatments. I'll provide one very famous example that played out in the news tremendously. Angelina Jolie chose to have a double radical mastectomy, right? She chose to have her breasts removed because she sequenced herself, and the combination of genes that she had meant that she had an 88 or 89% probability of getting breast cancer. And she made the choice not to face those odds, right? Which is probably what many people would have done. And so you avoid it. If you look purely on cost, forget the all the other stuff, but just on cost, you paid, I don't know, $800, $1,000, maybe a bit more because you have the consultation to go with that, to avoid tens of thousands of dollars of cost at least. So just looking at it from a cost efficiency perspective, what a wonderful thing to have.
So how far away are we from it being routine?
I don't know the answer to that. It's probably not as routine as I think. I'm not sure if Nadeem has an opinion on that, but it's at the moment it's not that routine.
Dr. Nadeem?
Yeah, no, I'm not really familiar with with the details, but definitely something that we're seeing a lot of companies now, big unicorns getting into, is how do we best use our best understand our genes. And again, for preventive reasons, it's great, right? Because I mean, at the end of the day, what you want to do is kind of lower your risk in the long run and lower your costs. And so that's something that, of course, there are a lot of ethical implications, right? And that's something that we haven't sorted out yet. I think the technology has outpaced kind of that discussion about ethics and policy, but very interesting indeed. I agree. Yeah.
Mr. Mashal?
Just following up on Dr. Sami's point about the
Genomic sequencing.
genome sequencing, etc., in terms of how you can be utilized. I'm going to take the frightening aspect of it, and actually the financially beneficial aspect of it. The frightening aspect of it is what you can do by just playing with people's genes. Maybe technically can't be done so much at the present time, but again, fast forward another 20, 30 years, 50 years, and it's a whole different ballgame. But what now you can do is you can have designer kids. You can actually, courtesy of a company called CRISPR, if I'm not mistaken. And you have this, can you imagine about 100 or 200, 100 years ago, a whole war brought the whole world together in a horrible war because of something to do with this. And now it's going to be available. And in fact, it's going to be encouraged because it makes you a lot of money, meaning eugenics. You can then choose what the baby is going to look like, how he or she, what gender, what color, the height, you can start doing this thing. Again, this is not science fiction. This is something that's starting to happen. And again, there's a part of me, I'm 52 years old, and I can't tell you how happy I am to be this age, because by the time all of this thing starts to happen and come to fruition, inshallah, I will be dead, and I don't have to experience this. So there's a part of me that's really happy. But in the meantime, if there are opportunities to financially make money out of it, I think that's it.
Thanks a lot, Mr. Mashal. We're going to open the floor for questions. We have Leah Zviglic. You are on. Go ahead, Leah. If you want to ask a question to our panelists. Okay, Leah. Yes, go ahead, Leah.
Hi. So currently we are in a very unique situation of experiencing innovation in healthcare propelled by the pandemic. So how do you see this spark of innovation in healthcare affecting overall direction of how we see this industry and the benefit from it?
Can I take that one, Mohammed?
Go ahead.
I feel today like someone who was staring at a computer in 1980 and a light bulb went off, right? So you had, for biotech, right? Or maybe healthcare 2.0, as I like to call it. And so, 1980, let's see, I think you had Intel, you had IBM, Microsoft and Apple existed, they were not listed at the time. So someone surely there are quite a few people that stared at a computer and said, "My, this is amazing." So it feels like that for biotech now. It feels like we're at the absolute bottom of the hill. We're about to rise. Now, biotech has been around since the 70s, and it has overpromised and underdelivered right until this point. And if we have 22,000 genes. I think we only make about 20 protein therapies, right? Insulin is one that comes to mind. It started in the 70s with yeast and that sort of thing. And so we've done very little on that front. But now we have a set of companies doing science fiction. I think you can call it that. Even to me, I come from the field, and if I step back, the things we're doing are amazing, right? CRISPR therapeutics, Michal just mentioned. The patient they have farthest along in the pipeline has been, this is for thalassemia, 20 months without a transfusion. That's remarkable. That's absolutely remarkable. And there's several patients that are sub 12 months. It appears very promising. Take, well, another company comes to mind. We invested in it when it was private, and then when it listed, and it was then a little known company that became a front runner in the vaccine race, and is now on the news all the time, Moderna. Again, what a beautiful company, right? It does things that could appear to be science fiction. So, and in 62 days, it went from having the sequence of the virus to delivering a shot into the arm of a person, right? In 62 days. Why? Because of a lot of reasons, but one of them is the technology that it uses. So Leah, we're there. It feels like staring at a computer in 1980.
Okay, and Dr. Nadeem, you want to add something to that?
No, I think that was very well said. I think yes. I think we're in places like here where maybe it's harder to pierce through the culture and the norms and the traditions. This has really shown that patients, I'd rather go online. I don't want to go into a hospital. So I think convincing a larger population that technology actually does help, does enhance healthcare, does improve your outcomes and your convenience. And I think that's clearly the I don't want to say beneficial side of COVID. I don't think there are any beneficial sides to it, but I think it's convinced us. I think that and of course it's triggered some phenomenal ideas, and not just for more developed and wealthy systems, but also for the developing world, right? I mean, it's initiated a whole series of innovations across different verticals in health. Yeah.
So we're going to move over to questions from the platform. So is there a market for digital tech businesses in the healthcare sector? Asking as I'm hoping to invest in a company. We already talked about that. The digital tech businesses. Maybe you can contact Dr. Nadeem if you want to invest in Sahati.
Please.
Go ahead. Should we be concerned about the amount of data we are giving away, especially when it comes to health and IoT devices, or is this just the cost of progress? That's a tough one.
Do you mind repeating the question? I didn't catch it.
Should we be concerned about the amount of data we're giving away, especially when it comes to health and IoT devices, or is this just the cost of progress?
Can I jump in on this point?
Go ahead, Mr. Rajan.
Yes, we should be very afraid. And the reason is not everyone has good intentions, and let's face it. And the moment anything is out digitally, it can be. Let's say you have a company that's very conscious about security, cybersecurity, and making sure everything is put properly and protected properly. For everyone that you have, every company that you have that does that, you have other companies out there who are trying to steal that data. So yeah, I'd be worried. But is this something you can stop? The answer is no. You can become a hermit and go live what you call it in a cave somewhere if you want. But as far as if you want the best approach to medicine, a best approach to shopping, a best approach to any of these things, the more data a company has, the more likely to target specifically to what you like. So it's a question of to what degree are you comfortable giving away information, and to what degree are you comfortable not getting everything specifically to what you want. I'm personally uncomfortable about certain things, and I will not share certain things. I just don't want to. And I'm willing to take the losses in terms of opportunities because of that. Other people say, you know what? As the questionnaire I said, it's a cost of business. I'm willing to take that. I'm willing to give that information away because it gives me what I want. I think everyone will take it in a different approach. Now, corporations want to get as much as they can. Governments want to get as much as they can. Individuals want to give as little as they can. It's a balance somewhere in between them.
Dr. Sami.
It's an interesting, more general debate, and we can apply to tech companies. It's tempting to do that. I won't go there. Sticking to healthcare, it's hard. I don't know what you do. I don't have a good answer. You can only hope that we have the right rules, the right debates, the right cybersecurity in place. As Mishaal said, it's a cost. It's a trade-off. How much do you want to access that technology or not? Do you need to or not? I think every individual will have to make a choice.
Dr. Nadeem.
Yeah, I think quickly, it's a cost benefit. It's understanding. One is I think setting the right examples is important, right? Because of the lack of regulation, it's always easy to kind of bend the rules and to do things, and that ultimately hurts everyone. I think if you're diligent and you set the right examples, right, and you're very transparent about how you use the data and how you store it, right? Use kind of the best measures of data security. You go beyond kind of the regional standards and you set something that, okay, your data secure, here's where we put it, here's what we're going to do with it. But also, I think on the flip side, digital health is an opportunity. And I think, as we've seen, we suffer a lot of stigmatized conditions in the region, right? And that's because of the social norms. Men and women, right? Talking about men's health and women's health, have difficulty accessing doctors physically because of that stigma, right? I don't want to go them for, I don't want to go see that doctor for my erectile dysfunction, right? And that creates a huge opportunity for digital health, because then you create a space where the patient can conveniently connect to you, and it doesn't have to be synchronous, it doesn't have to be looking at a physician online. It can be just by filling out a form, right? We've seen companies, such as Roman in the US or Hims and Hers, IPOing. Those are focused purely on the stigmatized conditions. So there is clearly a huge market for digital health and for creating kind of, it sounds, counterintuitive, or it sounds, again, going against this argument of kind of data being out there, but it does provide this window of security, of privacy, that you can then address your needs. And we, like many other digital health companies in the region, are seeing that trend and are seeing that those needs being, that huge demand for those services.
And Nadeem, if I may, I'll add mental health to that.
Huge.
Right, that's another big one, where a lot of it can be done virtually, and in our societies we have a huge stigma against that. People don't want to be seen in a waiting room of the psychiatry department in a hospital. I came across an app recently that's working just on mental health, digital prescription, so opioid addiction, insomnia. I think they had one other thing that I'm not remembering at the moment. Maybe it was depression, but that's another one.
That's a huge one. And looking at another example, Modern Health in the US, right? Mental health play. They were now worth over $1 billion, and they founded 3 years ago. Mental health is a massive area of media. Yeah.
There's one slight difference between ourselves and countries in the, let's say, economically developed countries of the Western hemisphere, in that socially, how many, if I was a CEO of a company and I saw a psychiatrist, or I had a psychologist in my organization, it would be seen as actually a positive thing, because you're trying to understand your mental state, and you're trying to understand the mental state of the people involved in the company, and try to get things better, because the more you understand how people think, the better you can, we have courses, organizational behavior in psychiatry, etc., which is important. And also, when you're under a lot of pressure, having people that you can talk to, who can help you overcome these things, meaning talking to a psychiatrist, etc., is something that's seen as a positive thing. Come to our part of the world. If you, as a CEO of a company, are seen or deemed to think that you're going to see a psychiatrist, oh, this is a company.
Shares are going to plummet.
There's an issue here. This guy, something wrong with him. Why is he going to see? It's significant. By the way, even Dr. Nadeem, you were mentioning about the company. Imagine, again, you're the CEO of a company, and you have need to go see a proctologist, right? Now, you need, there's a camera, you don't want to go see the proctologist. using the camera on your telephone, etc. You're taking pictures of something in that nether area. Urologist, proctologist, whatever the case may be. You're taking pictures of your nether area. As a CEO of a company, if that information leaks out in our part of the world, you know the negative ramifications that will come out of that. In other parts of the world, it will be seen as and move forward. And it's just something unimportant because it was not something that was done with sexual nature intended, sexual intention. But in our part of the world, this small little thing would be enough. Even going to see what do you call this? Doctors for the
Cosmetic surgeon.
Yes, if you go to see that some people are vain enough that they want to fix their nose, not because they actually have an issue in their nose, but they want to fix their nose. Fine, that's a choice. But if you do that and you have to take pictures, and because it's not somewhere that you can hide, you can have your front face, and that gets leaked out, there's a problem. People start becoming. We work in there's a lot of things that go against us because it's an issue to do with the society in terms of how we address things. I don't know how. I'm not saying these things because I have an answer to them. I don't. But I do know that the negative effects from these things on business would be significant, versus in other parts of the world that will be just thrown aside. It is something that was leaked out, but who cares, and you move on. It doesn't have a negative effect necessarily on anything to do with that person's life, business life. But it might have an effect on his personal life, but not on his business life or her business life. But in our part of the world, there is no differentiation between personal life and a business life, which could have an effect if you happen to be the boss of a public listed company. How do you address this? Again, this is a question mark, not to get an answer, but these are things that we have to also consider when we look at that aspect. Yes, there are positive aspects to having digital connectivity, digital pictures, distance away, but there is also the issue of privacy. And you know what? When you have that relationship with a doctor that you can talk to that person and open up about a lot of things, it becomes that much more sacred. How do we transfer that from a one-to-one onto a digital platform? I have no idea, at least in our part of the world. Again, maybe I'm generalizing, but if you have better experiences in this, I'm willing to listen.
We're going to find out. Thanks a lot, Mr. Mashal. Thank you. I really appreciate having you on this panel. Dr. Nadeem, thank you very much. Dr. Sami, I really enjoyed having you guys on this panel.